Thank you all for joining. Hope everyone had a good Thanksgiving. Today's presentation, we wanted to talk about AI and healthcare and AI, and it's definitely a hot topic these days, with just advancement in technology and kind of where healthcare is going. And so I wanted to introduce our speaker today. His name is Dr. Eric Alford. I've had the privilege of knowing him for just about a year now. He's the Regional Chief Medical Officer at Baylor Scott and White in the Brenham region, over primary and specialty care, and has really just been, in my eyes, just a big proponent of AI, just an innovator, always willing to try new things. And so I thought he would be just a great speaker to come and talk about this hot topic. So I will give off the floor to Dr. Alford. I'll be monitoring the chat if anyone has any questions along the way. And then at the end, we'll have just a time for Q&A with Dr. Alford. So, Dr. Alford, you have the floor.
All right. And Andrew, let me make sure that I want to make sure y'all can see my screen here in just a second. Are y'all seeing my presentation? Perfect. All right. So yeah, Andrew, thanks for inviting me here. And guys, it's a privilege to be here today. I always preface when I'm talking about AI is to his point, I'm a physician by training. I'm not an informaticist. I'm certainly not even a tech guru. But I recently kind of unexpectedly got into this space and have thoroughly enjoyed it. And in fact, this has become one of the coolest projects I think I've ever worked on in my life. My passion is still seeing patients, which I do 3.5 days a week, but I'm on the admin side about 1.5 days. And I definitely see the future showing more admin time in my future, but I'm relishing seeing patients as long as I can. As you guys know, AI is incredibly quickly evolving at this point in time, but I kind of want to go back into history before I get involved in this in the current state of AI. I mean, it was as I've kind of dug into AI in this world, I was fascinated when I first found out how long AI has actually been around. I mean, people actually started dabbling in it in the 1950s and the 1960s. But as you can imagine, a lot of AI requires data and it requires previous experience in literature and things that were not necessarily easily accessed at the time in the 1950s and the 1960s. And we didn't have the computational power to look back at data over long periods of time. When I was telling my wife briefly about this presentation, she said they actually had computers back then, and I had to remind her that we landed the rocket, or we landed on the moon in the 1960s, and we're really diving into mainframe systems, but they weren't around long enough for the data to actually be found and utilized. And so then in the 1980s, there was a lot of machine-based learning that actually enabled some applications that really started at this point trying to mimic that human decision-making process. And an example was something called mycin. If you've never heard of this, mycin is the ending letters of a lot of antibiotics, and it was actually used for infectious disease. And different than taking data sets from computational models or from computers, it actually instead used a set of rules based on expert knowledge, so physicians and scientists, and it allowed it to identify bacteria. And then based off of those rules, it would recommend not only an antibiotic, but a weight-based dosing for that specific bacteria. And it helped to slow some of the progression and some of the really bad negative outcomes associated with severe infections, in particular, sepsis and SIRS at the time. But then, as you guys know, the 21st century is where things really started moving. And it's interesting when you look at AI and you think about the last 5 to 10 years, and just like a lot of things in computers, it really took off over the last 5 to 10 years in a way that surpassed anything that was done in the previous 50 years and maybe even longer than that. And so we finally had those computers available with data sets that we had looked at for many, many years, and it allowed us to really dig in there and to use AI to the best of our capabilities. And I would venture to say that the best is yet to come here. But it really started diving into the healthcare world, and particularly around things such as medical imaging. And I use this as an example all the time. I think it's pretty simple to have a computer look at thousands of MRIs of the brain and to be able to fairly easily pick out the abnormals from it And I say easy with the, pretty lightly there, but it makes sense that you can see the differences. But then when it started getting into personalized medicine and drug discovery, so really trying to figure out what the best medication uses were for certain conditions, personalized medicine, that we are really tailoring therapies towards not only disease processes, but towards individuals. It made a huge difference. And then now what we're seeing in the healthcare world in particular is these diagnostic tools that we can use to help patients, virtual health assistants, which I'll kind of briefly talk about in a little bit, and then really cool predictive analytics for patient management. So in some ways, forecasting what a patient's healthcare is going to look like a few years from now, even when you don't even have symptoms that suggest it. So what we've seen is, again, just the beginning in healthcare, and I'm going to focus on that piece. So today, AI is truly an integral part of healthcare. There's no doubt it's going to affect every possible realm within healthcare. And yet, and understandably, I should say this, people fear AI. And in particular, a lot of people fear that AI will replace physicians and many others, not just in healthcare, but throughout the world, throughout different entities. But I truly believe, and I heard this said the other day, is that physicians who use AI will much more likely replace those who don't use AI. So we really need to embrace it and figure out how to best use it, not only to support our current work practices and workflows and efficiencies, but to benefit patients as well. So as I told you before, I'm not a trained informaticist. I'm not really anything to do with computers other than getting involved in this AI journey for Baylor Scott and White Health, which is who I work for and who Andrew works for as well. And so I want to kind of dig into the background of this and share with you some of the experiences that I've had with Baylor Scott and White. For those of you who don't know, really briefly, it's the largest nonprofit health system in the state of Texas, and it's one of the largest in the country. In particular, I want to call out that we have 1,250 healthcare sites. We cover over 1.2 million lives. And then we have over 7,100 physicians and many more APPs in that number. In particularly, we also have 3.1 million My BSW health accounts, which is our version of MyChart for Epic. And that's really important because a lot of the AI work that we're doing within our organization, again, caters to the patients. And one of the ways we do that is through our MyChart accounts. Several years ago, probably 3 to 5 years ago, there was a body of work that was created within Baylor Scott and White called the Medical Group Transformation. And within that medical group transformation project, they really looked at every single touch point in a patient's lives. And I'm talking from the moment they call to schedule an appointment to the time they walk into a clinic, see the provider, leaves the clinic and or hospital. But it also looked into things like billing and transparency of the charges going towards the patients. But it aimed at not only helping the patients, but to also help the providers. And in particular, one of those work streams was called the Provider Empowerment Work Stream. And this is when I kind of got involved in it. I was asked to lead the lowering documentation burden piece of this provider empowerment work group. But when it comes to AI, really the first thing that we started doing was what was called augmented response technology. And I'm going to talk to you about that in depth later. And it was kind of a project that I dived into or delved into, but was not necessarily the clinical lead on. But it was definitely the first piece of AI technology automation that we used at Baylor Scott and White. The way we started with the lowering documentation burden piece of this is we know, and I'm going to make this clear from the beginning, we know that burnout is real among providers, and you guys know that too. But what we wanted to focus on was not the term burnout, but rather MD well-being or provider well-being in this. And this includes APPs, obviously. The number one, if you ask any provider, what is their number one thing that decreases their well-being, is almost always unanimously lowering documentation burden because of the amount of paperwork that we have to do instead of just seeing patients. So the way we did this is we first tackled what's called an APSO note, and I'm not going to go into details on this, but it's where basically you put the assessment and plan, the meat of the documentation of the note at the beginning of the note. Because if you've ever looked at records of your own or records of somebody else, the first thing we typically do is we scroll down all the way to the bottom of the note, find out what the doctor said and what he or she did, and then we stop reading the rest of the note. And then part of that came from the 2021 E&M CPT coding and guideline changes, which allowed us to finally take a lot of the minutia out of the notes and focus on what was most important for the care of the patients and to make it easier for the patients to read. And so we started there, and then we ended up going into the ambient listening world, where we really interviewed and vetted multiple different vendors to try to figure out what the best way for us to leverage our APSO note and some of our current documentation with the ambient listening platforms that are out there today. And as you guys know, there's I mean, tens, if not hundreds of AI ambient listening platforms out there. But we ultimately chose to go with Microsoft DAX, or Nuance DAX, which was purchased by Microsoft. And that's for the remainder of this AI ambient listening solutions talk. I'll be talking about Nuance DAX in particular. As I told you, though, the very first thing we dabbled in was augmented response technology. Essentially, what we saw is when we surveyed all the providers, we found that 92% of them said that they were really heavily burdened by patient medical advice request messages. So messages that the patients were sending us on a day-to-day basis and asking us to field them. And many of us were getting 30 to 50 or more of these messages every single day. And we had to do that in between seeing patients or at lunch or maybe after work. And it was really burdening us. And what we also saw was that there was a historical trend for getting more of these. And a lot of this, as I'm sure y'all are aware, started during and after the COVID pandemic. And so we also started looking at a lot of different Epic data on this, and we realized that we were in the bottom quartile for messages received per day for providers. And different people have treated this differently. So some organizations have chosen to charge all patients for their patient medical advice requests, which you can do. And we have adopted to an extent, but we wanted to make sure that we weren't nickel and diming every patient who just wanted some simple advice from us. And so we started looking at ways to fix this. And part of those were routing to clinical, either medical assistants or nurses to look at them first and to mature those messages. We really heavily trained those care teams, and then we moved them on with different experimental staffing models, and it helped a lot. But what we really were looking for was a solution that reduced the administrative burden of these PMAR messages on the providers themselves. And what we found was that ART, or augmented response technology, was our best bet. So augmented response technology, what it really simplistically, what it does is if a patient asks a question, it actually uses, again, AI. So it's using all these data sets, no different really than if you Google and you see the AI responses, depending on which platform you're using, but the Google AI assistant or whatever that sends a message back based off of what you told them or what you're asking, and then it would send them a message. And what we realized was that was great, but it didn't necessarily change a lot from if you were doing just that, you were Googling for an answer. And so we wanted to make sure that it was really well structured. We really wanted to make sure that it was sympathetic and empathetic in tone, which we were able to capture by dialing in on certain characteristics. And then we wanted to make sure that it was time saving so that a provider could look at the message and feel comfortable enough with it that they could essentially send it on with very few or no edits. And the way we did this was by actually changing some of our what we call prompt snippets. And so we would change things so that if a patient were to ask a question such as, "I'm pregnant, what do I need to do?" instead of just giving them a response that was specific to the pregnancy that they might be able to find on Google, we were able to change things with specific keywords and then creating rules based on those. So a new pregnancy, as an example, would tell the patient, instead of just saying, "take your vitamins and go see an OBGYN, it would tell them, avoid these medications, start taking a prenatal vitamin. And by the way, by 8 to 10 weeks, you need to be seeing an OBGYN. But instead of just stopping there, we actually provided the opportunity for a patient to schedule an appointment to see one of our OBGYNs with a list of physicians that were available. It gave them the option of scheduling a video visit versus a face-to-face in-person visit. But we really personalized it towards the patients to make sure that they got all of the information they needed. And what we captured by doing that was a major reduction in the additional responses that might have stemmed elsewhere. So if you were just telling them to see an OB within the next few weeks, we didn't want them to send a message back, "Well, how do I schedule that appointment?" We wanted to make sure it was all contained in those responses. And we did this using an Epic architect, so a consultant that we use that really understands Epic, which is our medical record system, and he helped us to create those prompt snippets to make it to where it was designed to meet the patient's needs. The other thing, and I put this slide in here because I think an important point to note on here is our organization chose the providers first, which means instead of working on the responses being catered towards the clinical staff, we made it where they were catering towards the providers. So that final push to the patient, what would a provider say if they were asking, if they were being asked those questions? And in order to do that, we had a provider-led team that they called us the Fab Five, but it was 5 physicians who worked together with these with the informaticist and then for early adopters. And we went through, I'm not exaggerating, hundreds, if not thousands, of different case scenarios. So if a patient writes in and says they have an elevated blood pressure, what would you tell them? And so we created those prompt snippets based on that, and we really mirrored what the providers would say to the patients, which I think led to the success that we saw. So I'm just going to quickly go through this. I don't know if y'all are into metrics. I love the metrics because I think the data proves that what I'm saying is not just what I'm saying or anecdotal, but it actually proves that it was legitimately good. What you're going to see kind of left to right on here is that we had a 14% improvement in provider response, meaning we had quicker responses, we had better responses, and then less as a result responses back to those messages. We also saw a 46% utilization among all of our pilot providers. And while you may look at that and say, well, that's a failing grade if it's less than 50%, it felt so much more than that. And I will tell you, I was one of these pilot providers, and I truly bet somebody, the Epic architect, that I was seeing or that I was using these more than 80% of the time, when in fact I was only using it 50% of the time, which is what kind of corresponded to the other pilot providers. But when you looked at it, the messages that I was using it the most on were messages that were multifaceted. So they may have had multiple questions built into one patient message, or it was a very verbose answer that I didn't want to take the time to respond to, but the AI did it for me. And so it just felt like it was much more utilized than I was actually doing it. But the cognitive burden reduction from that was huge. And then what you see here on this 74% end basket satisfaction, prior to implementing augmented response, we had about a 40% in basket satisfaction, despite everything else that we had done prior to this. And when we were able to use this augmented response technology, we went from 40 something percent up to 74%, which was huge. And then as you can see, we also saved about 32 seconds per message, which over time adds up significantly. And at a system level, that was hundreds of hours that we saved the providers. And then from there, as I told y'all, from a timeline perspective, we went into ambient listening. And so we vetted, like I said, multiple different vendors. I will be the first to tell you, I think they are all really good options. I think there's probably a handful of options that are prime time and ready for prime time and are truly good enough to be implemented into real world practice at both the ambulatory and the hospital setting. But again, we chose Nuance DAX. The main reason we used it was because it came, we have a Microsoft suite of products. So there was also a scalability piece of this and an expense perspective, but it was also owned by Microsoft. And our gut was Microsoft's probably not going to sell this technology, and Microsoft will certainly probably not sell itself. So we thought long-term the stability was there. So the way that Nuance DAX works is very similar to what most ambient listening platforms or how they work. And so the cool thing about this is I can, right before I walk into a patient room, just say, I've got a 32-year-old male here for an annual wellness exam and follow-up of hypertension. And I don't even have to tell it that, but if I do that, it'll denote what that patient's being seen from, and then it'll kind of grow from there. But I can also say the patient is accompanied by his wife. Or whoever else is in the room, and then it can depict the however many you have different voices in that room, and it can determine who is saying what during the conversation. And so you walk into the room with this device, you set it down. Mine's used off of my phone, so I'll set my phone down in between me and the patient, and I'll just start talking like I normally would, and having a normal conversation with the patient. It records the entire conversation, but when I'm done recording, it takes that note, it takes the dialogue, I should say, and it generates a note that put inside of Epic. The coolest part of this is, and I can tell you as a prime example, during the presidential election, there was a whole lot of conversations going on that I did not want in the patient's notes because they got to be pretty controversial. And there's a lot of other, obviously, personal tidbits that we talk to patients about. And it actually weeds all that information out, and it only puts what is medically relevant into the patient's chart or into the clinic visit note. And then basically it tells us that it's ready to be reviewed and edited. We go in there, we've created a hard stop. So it forces the provider to look over the note to look for accuracy in there. And then you can add some modifications if you want to, and then you sign the note and you're done. The entire process takes about 20 seconds or less for a note to be created. And then it takes less than a minute for me to finish my notes because it's gotten that good. When I first started it, which was back in May, it was not that good and it took a little bit more time than that, but it's gotten to the point where we joke, we don't know if DAX is learning us or we're learning DAX, but either way, it's getting better and better every day. And so today I don't have to do a lot of editing or modifying. And in simple patient cases, I typically don't even read the note anymore. So initially, and I should say this going back, I forgot to say one thing is that with the ART responses, the augmented response technologies, it's now available across our system. And what you're going to see is a similar outcome here too. Is on the ambient listening piece, we had 154 initial pilot providers. One of my main goals was to make sure that advanced practice providers, so your PAs and nurse practitioners, also had an opportunity to use this, because prior to this, none of them had the opportunity to use human scribes or any other form of scribing services that we had within our organization. So we took a mixture of physicians and APPs across 90 different locations within our medical group. And we used, this number is way understated now, but we've now used over 110,000 ambient encounters to gather the data that we needed prior to rolling this out to the rest of the system. And so among those pilot providers, 70% of those utilized it when they were actively on DAX. And there was a 20% opt-out rate among providers. And we tell everybody from the beginning, it's not for everybody. You do have to learn to use it, even though it's pretty simple. The notes are not beautiful. They're certainly not what we are taught to do in medical school. But if we joke, we created a hashtag called care less, meaning don't worry as much about the bolding or the italicized or different formatting options. If the note is there and it can get the message to the patient, or it can get it to your provider partner, it's doing the job that it needs to do. But that 20% opt-out was really towards the beginning of the pilot phase, where we were still learning DAX and vice versa. And today we have a much lower opt-out rate among the providers that are using it, that are outside of this pilot group. In order to assess how well it was received by the providers, and so that we knew if it was working or not, we assessed that pilot provider group at baseline, 30 days, 60 days, and 90 days. And all additional cohorts of providers that use this were just assessed at baseline in 90 days. And all of the numbers really matched up across national standards and other national surveys that were done. But it helped us to learn that over time, the providers were much more accepting of it. And so what we learned is that among that pilot provider group, and I told you earlier, is that we wanted to reduce burnout. We wanted to really focus on provider well-being. What we saw is among that provider group, that pilot group, we saw a decrease in 80% of burnout symptoms overall. And that led to 102% improvement in a burnout score, which I'll kind of show you on another slide. I can tell you, as a provider, I've never experienced a technology, service, staffing model, you name it, that has that kind of a burnout reduction. But as a pilot provider, I saw that and more. It's truly an incredible technology, and I think it will be a game changer moving forward. But what we also saw was a 59% increase where pilot providers felt like they were actually finally able to give more than 75% of their time in those face-to-face visits, giving the patient undivided attention. We went into medicine to practice medicine and to be with patients and to learn them and to interact with them and have a relationship. The computers took away from that. Many of y'all may have seen the cartoon drawing in the past where a child was asked to draw a picture of her visiting her doctor, and the doctor is facing away from the patient, typing on the computer. And that's the world that we lived in, and we still live in to an extent, but our goal, and we know this is a far-fetched goal, but our goal is to kill the keyboard and to get rid of the keyboard so that we can actually take care of patients the way we went into medical school to do. After using this for 90 days, providers also had a significant 86% of them, in fact, felt like they finally had enough time to complete their documentation. And you're going to see comparisons really briefly here in a second. We also saw an increase of 60% of providers that said that they were able to see an additional 1 to 5 patients per week, which, as you can imagine, in most models, not only creates more access for the patient, but it also creates more revenue for the healthcare system and for the providers themselves. And that was not the goal of this project. We did not go into this saying, if you have ambient listening, you have to see a certain number of patients. This was literally given as a no-cost solution to our providers as a way to improve their well-being. But this is what we saw kind of organically happen over time. And then we also saw a 21% increase in time savings, which amounted to about 3.3 hours saved per month per provider. And as someone once pointed out to me, if you add that up over time, that's over a week of basically time back into your life to spend time doing what you love the most, whether it's just doing something fun or spending time with your family or friends. It's a significant amount of time each year for each provider. And so when I talked about the differences here, this is if you look at the 3 different versions here, the 3 different charts, is that left side was that increase of 60% where patients or providers are finally able to give face-to-face undivided attention to patients. And if you look at that, it completely flopped from the majority of providers saying they had very little time with that, all the way up to the response that we saw of the 60% at 90 days. And then that middle one where you see it again, the big circle and the little circle completely flopped on the completed time for documentation. And on the right side, that provider's perception of burnout. So if you look on the right side, that's where that 102% burnout score improvement came from. Literally going from being constant feeling of burnouts or completely burned out, they needed help, to having no symptoms of burnout or stress, but not burned out at all. So huge, huge improvements there. And then anecdotally, I'm not going to spend a lot of time on this, but we gave a really kind of a white glove experience for the providers who are getting on DAX, and we continue to do so as we roll this out to the rest of the system. But what you'll see if you read some of these comments on here is that this was a total game changer for people. I'm going to show you some anecdotal stories here in just a second that I think are worthwhile to show you. But to me, one of the most compelling stories is a physician in one of our regions was actually phasing into retirement, and he was given the opportunity to use DAX. And instead of phasing into retirement, he actually opened his practice back up full time, 5 days a week, and decided that DAX was going to keep him around for a few extra years. As administrators, as future administrators, if you're not already there, you guys know it is a whole lot cheaper to retain good talent than it is to recruit new talent, especially physicians. It's just incredibly expensive. We believe that this is going to help with that retention. So if we're right, we should see a significant reduction in expenses in addition to those additional patients that we're seeing as revenue sources. Again, not going to spend a whole lot of time here, but what you'll see here, as you can imagine, when people first started using ambient listening, their likelihood to recommend to other providers was a lot lower. But after just 90 days, that pilot provider group, we had a 64% of our providers saying that they would recommend to other people. So that promoter score significantly increased over time. And these numbers are just for that first pilot group that we had over 90 days. While we don't have any other groups that have done it for 90 days, we're seeing much higher numbers on these and all the other metrics that I've shown you. Really quickly, just to kind of show you some case examples here is Dr. Abraham was one of our physicians. He actually, after using DAX, he changed all of his schedule template from 30-minute visits to 20-minute visits, which yielded him 32 new appointments every single month. And as a result of that, he increased his RVUs by 12%, which again is increasing revenue for him and the clinic he works in. And he uses it 89% of the time. So we saw a huge increase in access for patients there. Dr. Edwards is one of our physicians in our North Texas division up in Dallas. Kind of a cool story. She I'm a twin, so I can say she was fortunate enough to have twins. And when she came back from her maternity leave, she was having difficulty balancing the work-life balance and trying to figure out how to see patients, maintain her quality of life from her revenue that she had seen before, and to also still have her twins and to be around them. And what she realized is she could triple book some appointments to drive access, which actually increased her coding overall, so increased her revenue, but it gave her well-being because she was able to get, or improved well-being because she was able to get home to her family a lot quicker. Dr. Bradley is actually one of my partners on this project. She saw a significant increase in worked RVUs in coding. She was one of our providers who had a closed panel, but she was able to add a lot of ad hoc patients because she had more time built into her schedule. And so it improved not only patient access, but her customer satisfaction. And we have another provider with a similar story who is a good friend of mine who I went to residency with. And she actually started opening up her lunchtime schedule for video visits because she got so bored online during her lunchtime because all of her notes being done that she started seeing patients over lunch. And then I'm only on this slide because I was the only one that was actually using a human scribe at that time. I'd used an outsourced third-party scribe vendor for over 10 years. And so overall, it was very difficult for me to make the move to AI. But when I got on this project, I decided it was best for me to do it. And I can tell you, I'll never look back. We have seen a significant reduction in cost associated with that move among several other of my region's providers who decided to transition away from the human scribes. And so you'll see that we had significant improvement in all those things that I just talked about. And then lastly, regarding ambient listening is, from my perspective, the most important thing is it finally gave us a chance to reconnect providers with patients. And what we saw was a fourfold improvement in our medical practice experience composite scores, meaning if the providers felt like their care provider was concerned and gave a good explanation to them, we had outstanding reviews among that pilot cohort. And so we've continued to see better patient satisfaction for those who are using this technology. Looking forward, there's a whole lot of other things that are coming down the pipeline, not just for Baylor Scott and White, but for just healthcare in general, and obviously outside of healthcare as well. But I'm going to focus on the healthcare uses. One of the things that we're seeing a lot of right now, and that we're delving into, is chart summarization. So it gives me the ability to look back, and I can look back over the last 6 months with only internal medicine physicians and summarize the notes for me, or summarize labs for me, or I can see what the last 6 hospitalizations were and have it summarize it for me, so I don't have to do a thorough chart summary or chart review in order to get my notes done. So that is a really promising piece of technology for us, especially with complex patients who have multiple chronic conditions. It gives us the ability to not take all the time that we normally do reviewing the charts, but actually seeing the patient and managing them. The other thing that we're working on currently, and we're fixing to roll out to a smaller group of pilot providers, is augmented response technology for result management. So it takes common labs like complete blood counts or complete metabolic panels. And if it's normal, it'll say your CBC was normal. Or if it says that the hemoglobin was a little bit low, it may say, of note, your hemoglobin was a little bit low, which means you might have anemia. We might need to do additional lab testing on you. But it takes, again, common rules with common outcomes and creates what we would normally ask to do as a next step for the patient review. And so we're really excited about that because that is our second most cumbersome piece of our end baskets in general. And then there's obviously lots of different ways that we look at risk assessment. Like I told you before, is really identifying patients who are at risk of conditions, even if they don't have noticeable symptoms, based on past medical history or family history or social determinants of health. We're seeing a lot of things that are improving administrative efficiency. So not just clinically relevant things, but how do we schedule better? How do we optimize our actual scheduling templates? How do we bill better and more efficiently? One of the projects I'm working on now is actually looking at how it can review my note and make sure that I have all of the elements that are necessary for the code that I'm dropping. And if it maybe has too much, maybe it suggests a higher level of coding that's more appropriate. But it really is aimed at improving operational efficiency. And again, hopefully with some of these things, increasing revenue along the way, because a lot of these technologies are pretty expensive. And then virtual assistants. And I put this on here from a patient care perspective. So really working with them on accessing information and care and streamlining tasks within clinics and hospitals. But again, as I'm sure you're aware, especially in the administrative world, how do we use virtual assistants or like Microsoft Copilot for summarizing a meeting, where it's listening to the entire meeting and then it summarizes high points and gives us action items. It can help to differentiate or maybe cover me for one meeting while I'm in another one. But really neat things coming down from that or down the pipeline from Microsoft and other vendors regarding that. So really limited additional opportunities are available. I would be remiss though if while we look at all of these new things, I want to just talk for a couple of minutes on ethical considerations, safe practices, and cybersecurity, because that is all three of these, but in particular, cybersecurity, I think is one of the hottest topics in healthcare right now after what we saw happen to significant major medical organizations here in the recent past. And I'm not going to go through word for word on these, but obviously we've got to work on data privacy. And so as an example of this, I do want to say that right now, there are not a lot of federal laws that say how long we need to have transcripts of patient interactions and dialogue. There's not a lot of things that we have to protect that. And so as an example, our policy is after 30 days, the transcript disappears, goes into a cloud. It's de-identified, and then obviously Microsoft and their company can use it to improve notes. But we have to figure out a way to make sure that all those transcripts and other healthcare data are encrypted to ensure compliance and safety among patients. Bias mitigation is another big thing, is that we want to make sure that we are not providing information based off of biased models. And so really looking at multiple diverse data sets before we actually implement this into the real world. Having transparent algorithms and the robust security measures. The robust security measures are obviously a huge one, but these are not just associated with ambient listening or AI, but doing everything we can to prevent additional future cyber attacks like we've seen before. We're focusing on continuous monitoring of all of these technologies that we're using now. We're really restricting access to the AI system to people who really need to be using it and should be the only ones that are using it at the time. And then trying to figure out if an incident occurs, making sure that we have protocols in place for responding to these breaches or AI related errors. And this is something we're working on really heavily with our legal teams and cybersecurity teams to make sure that if something arises that we're able to adequately deal with those issues. And then we're also working with Microsoft as a development partnership with them to know how they're doing it and what they recommend in those situations. And then from an ethical perspective, really truly prioritizing patient safety and well-being to make sure that what we're giving them meets their needs, but predominantly is doing something to improve their healthcare and improve their outcomes, and not just solely focused on reducing the burden that we see with providers and that revenue piece that I talked about earlier. So in closing, and I'm going to kind of read this. This is just kind of my take on this, and it elaborates a little bit on one of my first slides. Is it's really natural to fear AI replacing jobs, but the reality is that AI is more likely to transform roles rather than eliminating them entirely. So we see departments where AI may in some ways replace their roles, but we can always reimagine how these employees work and put them in different departments. So really transforming them. But those who resist embracing this AI technology really risk being left behind as the workforce evolves. And so I think it's incredibly important for all of us to adapt to the AI technologies. But I'm looking on the screen over here, and I can see at least a few younger people on here. I harass Andrew a lot about this. I'm going to take the opportunity to do so. I think it's going to take people like you. I think it's going to take providers and administrators working together to make sure that we're using this correctly, that we're using it safely and ethically. And I think if we do that, we're going to be in a lot better place here in the next few, I would like to say the next few years, but as fast as this is moving, I think within the next few months, meaning probably less than 2 years, we're going to see a whole different healthcare rejuvenated workforce that we've seen before. And I've truly never seen anything move as fast as this is moving. So I've certainly am biased on this, but I have high hopes for it. So with that said, I hope that didn't bore you guys. Do you have any questions for me? Andrew, is there anything in the chat?
No, nothing that I see.
Any questions?
Thank you, Dr. Alford. I have a question. So what happens when it doesn't work? So
So meaning the technology itself?
yeah,
Yeah, it's
like
it's a great. Go
we
ahead.
have a couple of courses that we give on Zoom, and the last one, for whatever reason, two of the sessions didn't tape appropriately, so we had to go back to a previous session and used two of the 10 sessions as previous recordings.
That's a great question. I will tell you, while we have had a few crashes on this, they have not been horrible and they've not been very long. But I will tell you kind of a funny two stories on this, or tangential thoughts, is Epic has gone out more than Dax has gone out. And the cool thing about that is when we go into Epic downtime, it is a clinical nightmare. I felt really, really guilty because I was one of 5 providers initially on this product. The longest downtime crash, if y'all remember the whole Microsoft, I can't think of the name of it, but when Microsoft did
CrowdStrike?
yes, exactly, yeah. So when it occurred and Epic went down for hours on end, I was able to continue documenting with Dax, and so I just recorded all of my visits. And by the time Epic came back up, all the other providers in my region and across the world really, who were not on this on a product similar to mine, had to go back and manually type or transcribe their notes. I literally had to click a button and every one of my notes showed up. So it was a huge benefit to have that, and I felt really guilty about it. Now I look back and I laugh about it because it was pretty awesome for me. But what we have seen is that when Dax goes out, or when any of these platforms go out, the response time in fixing the issue is pretty quick. And so typically it's a matter of minutes rather than hours. But to your point, physicians freak out, providers freak out when it happens because we get so used to this so quickly and not having to do our notes. You would think, the world is falling apart for the few minutes that it tends to happen, but they've been really, really good and really quick to expedite the downtime and bring it back up. And typically when they do that, they can also go back and recover some of the transcripts from before, and pull them forward, so that the work is a lot less cumbersome for providers when Dax goes down than it is when Epic goes down.
Thank you.
Absolutely. Yes, ma'am. Cecilia?
Yeah. Hi, Dr. Alford. Thank you for this. This has been really helpful. I was wondering what safeguards are in place to ensure that transparency with patients regarding the role of AI in their care.
Yeah. So, and if I don't answer the way that you're asking, let me know. But from a safeguard perspective, going from the very beginning is, interestingly, at least in the state of Texas and several other states, and I'm going to start here, is that we are a one person consent state, which means that as long as I consent to using AI, they're okay with it, and legally we can do that. We go beyond that, so we have signage in every single room. The providers are instructed to make sure that they're telling the patients that the conversation is being recorded and that it's going to be used to formulate the note. When the note is actually populated at the bottom of the note, there's another kind of an attestation statement on there that says that it was clearly formulated using an ambient listening device or an AI technology. So errors on there may be due to the AI piece of this, but that it does require a physician or provider to proofread it. And then all of that is done prior to sending it, obviously, to the patient from a record transparency perspective. So just like everybody with current regulations in place, the notes are fully transparent to the patient, but they know by the time they get the note that we've gone through all of this. And then on the back end is that transcript piece that I was talking about from a security standpoint. Is the transcript is actually only available to the provider who's dictating that, or who's doing that visit itself. And so for 30 days, I can personally go back and look at it with the information, like patient identifying information on there. But if someone else is looking at what we call the session ID, so we've asked somebody to review it to see where a problem was for improvement, it de-identifies it at that point. So it takes away all the HIPAA, or putting another way, it keeps it HIPAA compliant, but they're able to look at the dialogue as an example of the transcript without names on there and without any clinical information provided. Their goal is simply to look at the transcript and see what the outcome was, but it again has been de-identified by the time it gets to them. And then after 30 days, that transcript disappears and is completely de-identified. So even the provider that was doing it, or that was involved in the visit, can't even see it anymore.
Okay. Okay, awesome. Thank you for that.
Absolutely. And I can promise you federal regulations are going to get stricter and stricter over time. So I think you're going to see a whole lot. I actually think we're going to get to the point where we're actually asked to retain the transcripts. And I think that's going to create a whole other set of expenses because I think we're going to have to figure out how we're going to store all those transcripts, which is obviously going to take up more data. And that's going to cost more money.
Right, definitely. And I guess slight follow-up to that, have you seen resistance or potentially lack of buy-in from the patients about the
So I work in one of the most conservative counties in the state of Texas, and there's a whole lot of conspiracy theorists within even my patient population. And I don't say that in a negative way or a mocking way. I'm just saying as a fact it is. I think that when we explain it to the patients, they realize, you mean this is going to make it easier for you, and this is going to mean that you and I get to have more face-to-face interaction. And when I say they all buy in, I truly have not had one patient, and I've had this now. I've used it. I think the last time I looked was like 1,700 encounters or something like that, or 1,700 visits. Not one person has said no to me. And across the system, where we're now shooting over 200,000 across our system encounters using DAX. We rarely ever find a provider who says that they've been turned down for it.
Okay, got it. Thank you very much.
Absolutely.
With recordings, has there been any concern about including that in legally for medical malpractice or anything like that?
Oh yeah,
Has that
that's
come
one of
up?
the first. Yeah, that's one of the very first questions we get when we roll it out to a new cohort of providers. Is I think everybody is worried about the medical legal ramifications of it and what is that transcript going to do. I will tell you what I've seen in my experience is honestly, I think it captures the truth. And I think in probably 99% of cases, the truth would actually help us in a medical legal situation. And what I mean by that is, as an example, if I'm documenting my own notes, and a patient tells me in passing, oh, by the way, I think I have chest pain, and this is going to be a very exaggerated example, but the patient's there for a wellness exam and maybe a runny nose, and then in passing they say I have chest pain, and you tell them something really briefly about the chest pain, but then you end up saying, hey, it's probably reflux, no big deal, just come back to the clinic. But you don't document that anywhere in the note because I'm typing my own note, and I feel like that was completely irrelevant. I can promise you Dax is going to hear the word chest pains and it's going to put it in the note. And so not only then do you have a transcript that you addressed it, but it's actually documented in the note that that you addressed it as well. And so not only does that bring a little bit more truthfulness to the note itself or more accuracy to the note, 9 times out of 10. And again, I'm not using this as the sole source of this is the best thing, but it also increases your coding on it because you may have talked briefly about allergies and this acid reflux, and maybe his left toe was hurting, but you didn't feel like that was relevant enough for you to manually type in there. But all of a sudden, you've got 3 problems in addition to a chronic care problem, and you've gone from a level 3 visit to a level 4 or 5 visit. So you see this, and that's where I talk about that truth is most of the time. I think it's going to be that it's better documented, and it's more accurate as well. Well, I appreciate y'all's time, and Andrew, thanks for asking me to be here. Anything, if y'all have anything else, let me know.
No, I don't see any questions in the chat. Yeah, I really appreciate it. Even working with you and working with all these, I feel like I learned a ton. So I'm gonna get that PowerPoint from you on the back end. So thank you so much for coming. Thank you everyone for showing up. Hope everyone had a great Thanksgiving. And thanks for sticking with us. So any other questions, we will log off.
Thank you.
Thank y'all.
Have a great night.